Well, hello, everyone. Welcome back to CRNA School Prep Academy podcast. I'm your host, Jenny Fennell, CRNA. And today we have a really cool topic, which is PACU handoff and what all are the components that go into it. I want to welcome a special guest, Kathy Zuniga. Welcome to the show, Kathy.
Hi, Jenny. Thank you for having me. It's a pleasure to be with you again and
Yes,
talking about safe handoffs. Yeah.
exactly. And I actually met Kathy Kathy found me through an email chain, but she runs a business called PACU Nursing Minutes, and she's really passionate educator, mentor, and she really loves to inspire nurses to, again, do this safe handoff. So I thought, well, what better way than to talk about here on the show, since our listeners are going into anesthesia school and are going to be getting or giving plenty of PACU handoffs. So, and again, some of you may have a PACU background, and so she just provides a really wealth of information. And why don't you go ahead and share, Kathy, a little bit about your background and PACU Nursing Minutes?
Yes. Thanks, Jenny. So I founded PACU Nursing Minutes about 2 years ago. And what I mainly do is I help nurses prepare for the certification test for either a post anesthesia nurse or an ambulatory perianesthesia nurse for CAPA and CPAN certification. Well, when I was practicing in the PACU, we would get patients out of the OR and we'd get report. You're writing down kind of the same information over and over and over again. But the first PACU I worked in, we had a very simple framed out outline of what we wanted to have. And so I took that simple framework and added to it over the years. After I left that hospital, I moved to a hospital that did more cardiothoracic procedures like TAVRs and things like that. And so it kind of grew from that. When I started the business, I thought, what could I do to really help the next generation of nursing streamline their thinking so that they're not missing a thing when they get report for that fresh patient? Because sometimes you have no time to prepare and they just roll out of the OR and they're coming into your bay. You don't get to look at the EMR and you've got to be able to immediately start getting report on that patient. I made this at home and I would make copies of it at work and just shove it in my work bag. And so whenever I would get a fresh post-op, I would just grab another sheet out of my bag. And I actually made it double-sided so I could fit 4 patients all on one page. So 2 on the front and 2 on the back, because sometimes I'd have a busy day and have 12 recoveries in my 12-hour shift. Sometimes it'd be 8 recoveries. You just never knew how quickly they were going to recover. This report sheet really just helps a new nurse and even an experienced PACU nurse not miss a thing. Some people might think it's a little overkill. I think it's just right. And I made it available for nurses on my website to download it as a free PDF. So they can take it and they can tailor it to their patient population. Maybe they work in a surgery center and it's just ortho and they never see like a neurotrauma patient. Everyone is free to take it and to tailor it. I've been approached by one hospital who has had nothing and they had some near misses. And so now they want to roll out a safe handoff process. And then they're going to go back and look at, has it improved safety and prevented complications? So yes, that's kind of how this safe handoff download was born through PACU Nursing Minutes. Jenny, you're okay if I maybe share my screen to just show you how the nurses could access it?
Yes, 100%. And we'll make sure for those of you listening to the podcast versus YouTube, you can grab the link for this in the show notes or down below in the YouTube comments. But yes, let's go ahead and see the website.
Okay, so if you go to PACUNursingMinutes.com, there is the Safe Handoff download. And once you click on it, you'll come to this page. And pretty much I was tired of seeing nurses writing report on a paper towel. And you guys know what I'm talking about because it happens everywhere. And so it really is, time to toss the paper towels and get standardized with a safe handoff because 80% of serious medical errors are related to miscommunication at the transfer of care, and that comes from the Joint Commission. It is a national patient safety goal for improving communication between caregivers at handoff. And if you were like me and you just got tired of writing, the same thing down, like the name and the surgeon and the OR room, it helps you to quickly get report and not be missing anything. It's a safety measure, really. And there was a study done by Harvard, and they looked over 5 years of 350,000 malpractice cases. So 30% of the claims were related to miscommunication. It costs about 1.7 billion in legal fees, and 32% of nursing cases involved one or more miscommunications. Within surgery, 26% had one or more communication errors. So that's more than a quarter of our surgeries are having miscommunication. So that's huge. Yeah. And then 48% happening in the ambulatory setting. It's a fast-paced setting, the ambulatory setting. So we really have a huge room for improvement in minimizing communication errors and improving our patients' outcomes. And if you're working in a large teaching hospital, I've worked in large teaching hospitals and then the very small community hospitals. But, depending on where you are, there could be over 4,000 handoffs a day going on in just one institution, and that's a day. For the ASA, it's a standard that all patients upon arrival, they are evaluated and a verbal report is provided to the PACU nurse who's going to be responsible for that patient. And it needs to be provided by a member of the anesthesia team, not by the OR nurse or the circulator. It can't be given. I had one time in a new place I was working, I had one anesthesia provider just say, "Oh, it's all in the EMR," and walk away. And I said, no. You need to give me a verbal report. Because we need to be able to ask questions, and then those questions need to be answered to the nurse's satisfaction for that to be a safe handoff for that report.
Love that.
And then the Joint Commission, they recommend standardization tools. So either through forms or templates, checklists, protocols, mnemonics, and avoid only using electronic or paper format. If people aren't familiar with the Laidlaw versus Lionsgate, this was a sentinel event with a patient death. The judge declared the PACU as the most important room in the hospital, because if certain things aren't communicated, there is a risk for serious complications. So it shouldn't be taken lightly. It should be standardized. It should be rolled out, a multidisciplinary process where all the teams are involved, the anesthesia teams involved, the nursing teams involved, the surgical team. So everybody has their say of what they want communicated in that report. And then these are just some other things from that Harvard miscommunication study: 23% of inadequate consent communication, 19% provider miscommunication, 13% unsympathetic response to patient complaints, 34% resulted in high severity injuries, 14% resulted in deaths, wrong site surgery, medication errors, delay in care, and sentinel events. So again, a lot of room for improvement in our practice. I do have a video about spreading the awareness about this free download for the safe handoff. And you just put your name and your info here, and then you can get the download sent right to your inbox. And then these are all the references from which I just referred to, which Jenny, I can definitely give to you to put in the show notes.
Oh my gosh, I would love that. And you guys listening, one that just popped in my head, this would be a great idea for your DNP project. For those of you listening, I would jot down this idea, because clearly this is a very impactful area that we all need to be hyper vigilant in and aware of. And so studying things like PACU, effective PACU handoff would be a great thing to study and do your DNP project on. And it would only help your institutions. I believe you would get a lot of support from the hospitals that you are doing this doctoral degree project in, because this is, again, a very big pain point, and something they know is very incredible as far as the impact it can make, whether that's good or bad. So thank you for sharing. That was really great, and definitely provide those links. And I guess let's go into this with what kind of information should a PACU handoff include? And let's maybe start from like top to bottom.
Yeah, so let's just go right to the report sheet, because that's really going to just keep us focused. So this is the download for the safe handoff report. So, first is going to be the patient's name, their gender, allergies, their code status, if there are any precautions that we need to be aware of, their age and their weight. So that's just standard demographic information. the name of the surgeon, the OR room, because that's kind of, if you ever have to go back to the OR, or if you need to call back into that surgeon, you want to know what OR room you're going to be calling into. So it's just, it saves you time if you have complications and you need to call back into the room to ask a question, what kind of surgery they had. So just room to list the surgery, and then orders. So if you have your surgeon's orders for phase 1 care, and you have your anesthesia team's orders for phase 1 care, and then, the name of your anesthesiologist or your CRNA, their cell number, the arrival time. This is important for billing and also for tracking and staffing, and just for regulatory. Many PACUs charge per minute for phase 1 care. Some charge per 5 minutes, some charge per 15, but I've worked in a place where they charged every single minute for phase 1 care. And then once we moved to phase 2 care, it was a different billing amount. So they wanted it right down to the minute. And then, so you plug in the time here, but you also do a timestamp on your EMR as well. What kind of anesthesia? So you can quickly circle if it was a GA, a TIVA, or a MAC. If they had a block where they did it, you can just circle if it was an LMA or an ET tube. If they had an OPA or in upon arrival, when you take it out, that has to be charted in the respiratory flow sheet on the EMR. So, because that's now when the airway is protected from being unprotected. So like in case they aspirate or vomit or something like that.
Oral airway, for those of you listening, in case you're like, what's an OPA? Oral pharyngeal airway. So just to clarify,
yes,
for some listeners.
Yeah, and your LMA, that's your supraglottic airway, and then your ET tube. Your ASA score, that's like your surgical risk score. The anesthesia team always comes out and says like they're an ASA 2 or 3. So it just kind of gives you an idea of their comorbidities, their risk factor. And then if you have your orders, a lot of times you will get report from them and they will say what they'd used for induction. So if it was like 2 milligrams of Versed, propofol, if they just got dosed with 50 of fentanyl, etc., if they got sucks and later on they start developing MH symptoms, just things for you to know, like if they had ketamine, that would be important to know. You're not going to go stir that patient up immediately. Rocuronium, if they had that on board, what kind of gas did they use, the SIVO or ISO or nitrous oxide. Then their PONV prophylaxis, so Zofran, Reglan, scopolamine patch, and these are all just they're important to know, because if they've already had Zofran and Reglan and a scope patch and they're still being nauseated, you're not going to go back to your Zofran or Reglan. You're going to maybe, do amend or something different. So it just really helps you figure out your rescue emetics if you have those problems in the PACU. If they got an antibiotic pre-op, that's important to know, especially if they had any implants. Multimodal analgesia, if they had gabapentin pre-op or Celebrex, Toradol, Tylenol. So you can know when can you give that 2nd gram of Tylenol if they already had a gram. Reversal agents, so Neo, glycopyrrolate, Sagamodex. And then if they needed any hemodynamic support in the OR, for me, that's important to know, because it's going to tell me if they're going to be a little bit more challenging, a little bit more hemodynamically fragile. Maybe they have a poor EF already. Maybe, they're, septic on board of whatever, maybe they had a gallbladder rupture. I had somebody with that, post-COVID. I was like, how does the gallbladder rupture? But they sat on it for so long before coming in. So just all of these things can prepare you for hopefully a successful recovery with no complications. And then other surgical things is the incision dressing. So where is it? You could add LP sites here, trocar sites. If they had a local drains, how many drains? You can put your numbers 1, 2, 3, etc., right, left. If they need to have a post-op chest x-ray, or maybe they need to have their hardware imaged before they leave PACU, that's very common with the total knees, the total hips, the total shoulders. And then past medical history. So this part, I gather, if I have time before a patient comes to me, like the OR says, so when we have time and we're not slammed, the OR calls and says, hey, we're closing. We'll be out in like, 15, 20 minutes. So, and then the charge nurse, and I've been charged, I let my nurses know as soon as I get that phone call from the OR room that they're closing and coming out. I assign the room, and then I let my staff know. And that gives them time for them to look up the past medical history, the past surgical history, anything neuro, cardiac, respiratory. All of these things are assessed pre-op. We always do a baseline skin assessment in pre-op so that we can identify if there was skin breakdown in the OR. GI, what was their PONV risk score? What was their stop bang score? Are they positive for OSA? Do they have their home CPAP? My OSA patient population, I'll go get their belongings. That's another standard thing that we do once we know the patient's coming, is we get their belongings, we bring it to the bedside. If they have a CPAP, we set it up. We have the oxygen bleed in all ready to go, so that once they wake up, we can put them on that and start reversing their atelectasis. Labs, was huge with COVID. Did they have a negative COVID? What are their recent coags, the recent ACT for our patients who've had heparin intra-op? And then I'm an old school nurse. I like to see my most recent labs. So I have my room for H&H, platelets, white count, your electrolytes, glucose. We always do glucose post-op on most of our patients nowadays, is kind of an industry standard. And then things to do, like we notify the family once they come out of the OR. We notify them once they're leaving phase 1 PACU and going to phase 2. So we always check, make sure we get our belongings. There's going to be a handoff either to the phase 2 RN or if you are the phase 2 RN, then you'll be doing handoff if they're going to go to inpatient, or you may just be discharging them straight home. If they're going to go to the room as an inpatient, like what room were they assigned? Is the room dirty? Do you have to wait, etc.? So all of those things can be put down here. If they have outpatient prescriptions that the nurses need to get from pharmacy before we discharge them home. And then the discharge time, again, that's when you finally wrap up your chart, and that kind of ends the billing cycle for these patients. Interventions, vital signs, like maybe we need to do neuro checks more frequently, or what's their pain management. This is where I kind of keep track of my fentanyl, my Dilaudid. I know I put it all in the EMR, but I also like to have it on the piece of paper, so I know, like, okay, I just gave that 3 minutes ago, I'm going to wait, so that I don't give too much opioids and suppress their respiratory drive. So it's just my way of having it as a quick reference, especially if I'm getting ready to go to lunch or I'm going to take a break and I'm going to be handing it off to a coworker. They should be, logging into the EMR and looking at the last dosing, but it's also here as well for a quick reference. And then input. So this is also what you get from the anesthesia provider, your CRNAs, their eyes and nose. So how much LR they had, saline or blood, what their lines are, if it's peripheral or an art line. Some patients have central lines, but most of our patients just have peripheral lines. Their EBL, if they had an OG tube in, and if they had output from that. Their urine output, we're tracking that because we report anything under 30 an hour. Venous access, arterial access. This is really important if you've got multiple sheaths for your cardiothoracic patients or for your IR patients. And then hemostasis time for your arterial time and your venous time. And if you're doing a lot of sheaths, I would even recommend to have a different report sheet, more focused, because you could have 4 different sheaths just so that you don't run into problems with that, and just making sure that you're checking your neurovascular checks on those groin sites.
Well, thank
you.
you.
And then
there's does it keep going?
Yeah, and so this is for patient number 2.
Oh, gotcha.
You can print it on both sides. So you can do 4 patients on one, and make sure you shred this. This is, it's got HIPAA information on here, so it always has to be shredded properly. This is my brain, my PACU brain.
Yes, that's awesome. No, this is really thorough. Thank you so much for sharing. And I would love to have this leave this up on the screen for a minute, because I would love to kind of go over my thoughts as far as giving that PACU report and some of the things that I have. You mentioned quite a few of them, but I also want to highlight maybe some things for those going into anesthesia school and getting ready to start clinical. What typically you will see in clinical. I will say this is very in depth, that if you were to fully fill this out before you gave PACU report, this would probably be the most thorough PACU report of all times. But I want to hit on some of the real big points here. Allergies is huge, meaning, especially allergies that are real allergies, not just, pollen or, I've seen so many random things like real true drug allergies, especially drugs that you anticipate them needing to give. Like Phenegrin, for example, if they're an allergy to Zofran, these are things that you want to make sure that you're making them very well aware of. And then one thing that I would love to stress too, that when you're communicating your handoff, the best, and this even goes for in the OR when you're talking to the surgeon, the best way to understand that they truly have had an effective communication is by making eye contact. And if you really want to drive a point home, have them repeat it, and that's always key. And if you think they heard you, make sure they've repeated what you said. And then I always, at the very end of my report, always ask them, are you happy? That is their last chance to have me do anything else for them. And then if I have a patient who, and you mentioned, who are maybe a little bit hemodynamically unstable because they've been requiring neo, don't, the last time you gave neo, don't lie about it. And this is a tactic I've seen CRNAs do. Well, I've seen them shoot, some neo into the leader bag and bring them over. Yes. And it's like, that's not an okay practice. I know you will see it done. I'm just speaking from my own experience and things that I have even seen in clinical that I'm like, that doesn't feel right. If it doesn't feel right, it's not right. So just don't do it. If they are soft, that means that you need to tweak your anesthetic and stay with the patient until they're stable. Hang out in PACU, do your charting, circle back around and double check on the nurse, make sure they're okay, because they can't easily push neo. And the only thing they can really do is give fluids and wait for some orders. And so you have the ability to stabilize a patient quickly. And that is your job as post anesthesia, is to make sure that they are truly stable for that handoff. And this is also why it's important, you guys, in the operating room to start this process early on. Some of your patients will require a neo drip throughout the case. Well, you better start weaning that neo off very early on. And if they're not able to wean off, something is not right. You got to check your labs. You have to and assess your depth of anesthesia, how much narcotic is on board, maybe what's their pain level. Maybe they're just so overly narcotized and don't have a lot of pain that maybe you overdid it. Well, that just means your anesthetic has to be lightened up as much as possible. Things like that we do. We don't typically do it in PACU lot, but it can be done as giving like an IM shot of ephedrine if they truly need a longer lasting effect of some type of drug to get them through the really sleepy, drowsy anesthetic aspect of recovery. But yeah, so allergies, if they, if like their BMI is over 50, I tend to point that out. And I also like to point out whether they were difficult airway or difficult mask. You mentioned things like what type of anesthetic, but I also like to let them know, hey, they were difficult airway, they were difficult mask, because if they were to lose that airway, and it was difficult for us to secure the airway or difficult for us to hand bag them, they're equally going to struggle. So I think I've also had PACU nurses want to rip that oral airway out as soon as possible because they want to be able to leave the bedside. And when they have an oral airway, they cannot leave the bedside. They're 101 at that point because it's considered an airway. The problem is, would you rather rip an airway out and then have to manually hold someone's jaw open because now they're obstructing constantly and desatting, or would you rather leave it and let them wake up a little bit? So when I anticipate these potential problems, I make sure I let them know, hey, they're a difficult airway, they obstructed, that oral airway should really stay in until they take it out. And ideally, you want to try to take it out before you even go over to PACU. You just can't always, especially in like a surgery center. You mentioned the quick turnover, how 45% of these issues occur in surgery centers. That is one of the main reasons why I could not do a surgery center. The efficiency over safety to me was a huge deal. And you were literally giving PACU report and you'd see them go and wheeling your next patient back. And you're like, no. Like I haven't even had time to say hi to my next patient. And you're taking them back to the OR. So I'd like run to the hallway and try to do a quick airway assessment before they roll in the room. And it was just not my cup of tea. But you can't, and there were sometimes you had to hang out, like I said, in PACU and make sure your patient was stable. Let's see, what else did you mention? You mentioned Those are all really good things. As far as like past medical history, for this
Mhm.
part, Kathy did mention like they can look it up in their medical records. However, I
Mhm.
don't go through a thorough medical history, but I do make sure I highlight the big things. Like, what is their most recent EF? Do they have stents
Yep.
in their heart? What is their most recent EKG? Is it abnormal? Do they normally have PVC, a lot of PVCs? Are they occasionally
Mhm.
slipping into bigemity? Things
Mhm.
that they would be like, oh, is this new? And so making sure you're giving them a big picture overview that they're a severe COPD and that they do require a liter of oxygen at baseline, or that again they
Yeah.
have OSA or CPAP and that their machine should be with their belongings. Um,
Mhm.
Labs, same thing. I typically don't go through every single lab, but I'll hit the ones that I know are abnormal or ones that I know they should
Mhm.
be keeping an eye on, like the most recent glucose that we checked intraoperatively, or maybe what it was in pre-op, their glucose in pre-op. So they know, okay, if it dropped by, 100 points and that's a big deal, or, because maybe
Mhm.
they were diabetic and maybe they accidentally still took some of their meds. And that's why I checked it intraoperatively or whatever it may be.
Mhm.
Maybe you gave um, some potassium, so that can affect your insulin, right? Or maybe,
Yep.
again, some of the things maybe you give a bunch of blood products, right? And so again, that
Mhm.
raises your potassium and it can affect your insulin as well, or your
Mhm.
glucose. So
Mhm.
all of these dynamic shifts back in the OR have implications when it comes to labs. Let them know what the most recent crit was or the EBL, and kind of estimating where their hematocrit may be based on their EBL. If they
Yeah.
were on a heparin drip, like she said, the most recent ACT, especially post EP lab or cath lab where you're giving heparin, you want to make sure that when the last protamine was given and what their
Yep.
final ACT was. Yeah,
Mhm.
all really important things. I'm trying to think what else. So when you mentioned drains and all those things, this is one of these questions that I used to get that I'm like, I do see what's going on over the drapes, but sometimes there's so many little tiny holes and incisions that I don't always count, or like, there's there two drains or is there one drain? I don't know. I just know there's drains. I just don't know how many. And so sometimes I don't always pay as close attention as I probably should to the drains, but these are things that you can easily pick up the patient gown and look. But if you can try to pay attention to the drains, or I have them ask me whether the surgeon used local, and sometimes I'm not necessarily always staring over the drape every single second while they're closing, and I didn't see
Mhm.
whether they use local, and they didn't tell me if they use local, so I don't know if they use local. So these are things that you can ask the OR nurse prior to leaving the bedside, because they tend to have a better handle on that, because they're the ones drawing up the local for the surgical team and things like that. So typically, like either a resident or a surgical resident of some kind typically comes with you to the bedside and gives those types of detailed reports on post-op imaging, labs, and things of that nature. Because as an anesthesia provider, anesthesia orders are one thing, but surgical orders, you wouldn't really know what they wanted for the patient unless you actually communicated that with the surgeon prior to ending the case.
So for the PACU nurse, for me, my report is not complete until I have my anesthesia orders and my surgical orders.
Hmm.
So for that phase one care. So when you like circle around on that very end and you're like, do you have any more questions? I always make sure that I see the orders in and they're there for me to release them.
Mhm.
Because if I don't see them and I can't release them, then they're not there and I can't give any care until I see them to release them. Because I can't get any meds, activated
Right.
on their MAR if they're not released
Yes.
and, in there.
And so sometimes
Um,
you're calling your anesthesia team or anesthesiologist to say, hey, we need post-op orders.
yeah,
I would say 90% of the time they're good. But even the
yeah,
surgical team sometimes delays or drags their feet on that. And so then you're having to have the OR nurse call the team. And so if it's anesthesia, that's essentially your responsibility to make sure the orders get there. If it's the surgical team, you need to let the OR nurse know, or if you see the surgeon or the resident, to let them know.
yeah, yeah.